Good morning, respected teachers and colleagues. Today's journal club is on the article titled Rucaparib in Men with Metastatic Castration-Resistant Prostate Cancer Harboring a BRCA1 or BRCA2 gene alteration. Androgen receptor-directed therapy and taxanes have led to improved outcomes for men with metastatic CRPC. However, these patients will eventually progress, and there are limited subsequent treatment options. Thus, there is a dire need for additional effective therapies. Approximately 12% of men with metastatic castration-resistant prostate cancer harbor a BRCA alteration, 2% BRCA1 and 10% BRCA2. Men with a germline BRCA alteration have an increased risk for prostate cancer and are more likely to have nodal involvement and or piston mets. PARP inhibitors can induce cytotoxicity in tumor cells that are deficient in homologous recombination-directed DNA damage repair, including those carrying loss-of-function alterations in BRCA genes. Basically, this is a diagram depicting the mechanism of PARP inhibitors. So DNA is continuously damaged by environmental stressors as well as endogenous activities. These cause either single-strand breaks or double-strand breaks. So for single-strand breaks, when the complementary strand is available, then base excision repair is the mechanism that is used for repair. And for double-strand breaks, the mechanism that is used is homologous recombination or non-homologous end joining. So part 1, that is a poly-ADP ribose. So this is a protein that is a critical component of the base excision repair pathway. So it binds to these DNA nicks and it activates catalytic activity causing poly-ADP ribosylation of the part 1 and signaling other components of the repair pathway. So it has a role in the single-strand break repair pathway, but per se does not affect the double-strand break repair pathway. So when patients have a concomitant loss of BRCA1 or 2 function that impairs the homologous recombination, the loss of part 1 function in such cases could impair repair and lead to cell cycle arrest and death in such patients. So coming to the NCCN guidelines for the patient group that was used in the study, that is patients who have progressed after prior taxane and hormone therapy. So options included for such patients include also the preferred regimen would be cabazitaxel or a re-challenge with docetaxel or other agents that may be useful in certain patient groups. For example, olaparib has been used in patients with homologous recombination repair mutations, cabazitaxel carboplatin, pembrolizumab for patients with MSI high status or deficient MMR or a tumor mutation burden more than 10. Mitoxantrone is used for palliation in symptomatic patients who cannot tolerate other therapies. Radium-223 for symptomatic bone metastasis, and Rucaparib, which is the agent that we will be studying today for BRCA mutation. So other recommended regimens included abiraterone, enzalutamide, and other secondary hormonal therapies. So coming to today's study, so this is Rucaparib in men with metastatic castration-resistant prostate cancer harboring a BRCA1 or BRCA2 gene alteration. This was published in the Journal of Clinical Oncology on August 14th, 2020. So coming to the study design, this is a fully enrolled ongoing international study. It is open label phase 2, and it is evaluating Rucaparib in patients with metastatic CRPC associated with DNA damage repair deficiency. So patients who were included were men who were aged more than 18 years with a histologically or cytologically confirmed metastatic CRPC with a PS of 0 or 1 and adequate organ functions, with a deleterious germline or somatic alteration in BRCA1, BRCA2, or in any other pre-specified DNA damage repair gene that may confer sensitivity to PARP inhibition. Patients who had progressed after 1 or 2 lines of next-generation androgen receptor-directed therapy and 1 prior taxane-based chemotherapy for castration-resistant disease were included. And patients were required to have to be receiving a concomitant GnRH analog or have underwent prior bilateral orchidectomy. Patients who had previously been treated with a PARP inhibitor, mitoxantrone, cyclophosphamide, or platinum-based chemotherapy were excluded from the study. Patients with an active secondary malignancy were also excluded. So coming to the methods, patients received a starting dose of 600 milligrams of oral Rucaparib twice daily. Dose reductions in decrements of 100 mg were permitted for treatment emergent adverse events of grade 3 or more of a persistent grade 2. So coming to the patient populations that were studied, so the efficacy and safety populations included patients with a deleterious BRCA alteration identified prior to enrollment who received at least one dose of Rucaparib 600 mg. Efficacy was assessed in the overall efficacy population, that is all available patients regardless of measurable disease status. It was also assessed in an independent radiology review evaluable population, that is patients who had measurable disease at baseline as per blinded central independent radiology review assessment and investigator evaluable population. Had measurable for investigator assessment. So the efficacy and safety analysis included all patients meeting the above criteria who were enrolled by May 8th of 2019. And the visit cutoff date for safety analysis was September 13, 2019. And the cutoff for efficacy analysis was December 23rd, 2019, to allow for a more complete assessment, that is to have at least 32 weeks of follow-up of the efficacy endpoints. The primary endpoint was objective response rate by blinded independent radiologic review per modified RECIST criteria and the prostate cancer clinical trials working group 3 criteria supported by confirmed objective response rate by investigator assessment in the investigator evaluable population. Secondary endpoints included the duration of response for radiographic response, the rate of confirmed locally assessed PSA response, which was defined as a more than 50% decrease from baseline, confirmed by a consecutive measurement more than 3 weeks later, the time to PSA progression, the progression-free survival, overall survival, and safety. Exploratory subgroup analysis of confirmed objective response rate and confirmed PSA response rate was done based on baseline disease characteristics, that is number of prior lines of therapy, measurable disease status, presence of hepatic mets, and age, and also genomic characteristics, that is BRCA1 or BRCA2, germline or somatic alteration, zygosity, and alteration types. Safety was assessed by monitoring treatment emergent adverse events, vital signs, laboratory testing, and physical examination. The dose intensity was defined as the actual dose received divided by the first dose. So the procedures that were involved in this test included central genomic testing of plasma or tumor tissue, archival or contemporaneous, or through local testing. Central testing was performed by Foundation Medicine, and germline testing was performed by Color Genomics. So assessment of response was done by CT or MRI imaging and bone scans done during screening every 8 weeks for 24 weeks, and then every 12 weeks thereafter. PSA assessments were done every 4 weeks. Treatment emergent adverse events were monitored from the first dose of Rucaparib until 28 days after the last dose. Adverse events were coded using the medical dictionary for drug regulatory activities and graded according to the National Cancer Institute CTCAE version 4.03. So the statistical analysis was done using a Simon two-stage design as a futility rule. So assuming a total sample size of 83 patients in the independent radiology review available population, characteristics of the design included a null hypothesis of objective response rate of 20%, type 1 error of 5% one-sided, and 90% power when the true response rate is 35%. The final number of patients was to be defined based on regulatory considerations. Confirmed objective response rate and PSA responses were summarized descriptively with frequencies and 95% confidence intervals. So a duration of response, time to PSA progression, and PFS was summarized using Kaplan-Meier methodology. So the duration of response was defined as a time from the date of the first confirmed response to the date progression was first documented plus 1 day. Time to PSA progression was defined as a time from the first Rucaparib dose to date of an increase of more than 25% and an absolute increase of more than 2 nanograms per milliliter above the nadir in PSA plus 1 day. So PSA increases had to be confirmed by a consecutive assessment conducted at least 3 weeks later, so that early rises, that is rises before 12 weeks, were not considered in determining PSA progression. Radiological PFS was defined as a time from the first Rucaparib dose to the date of first objective evidence of radiographic progression or death due to any cause, whichever occurred first. Also, the best change from baseline and the sum of the diameter of target lesions and PSA was summarized graphically, that we'll see later, and statistical analysis were performed using SCS version 9.4. So coming to the baseline characteristics of the patient's study. So the median age of the patients was 72, predominantly white population. So 85% of patients were white, with the performance status of 0 or 1 predominantly. And the median baseline PSA was 61, with 77 patients, that is 67% of patients having a Gleason score of more than 8 and diagnosis. So a median of two prior CRPC therapies had been received by the patients. And so most commonly, next generation androgen receptor directed therapy, that is abiraterone or enzalutamide, were received. 42 patients, that is 36.5%, had received more than or equal to 2 androgen receptor directed therapies previously. Docetaxel in a castration sensitive setting was received by 14.8% or 17 patients, and in a castration resistant setting were received by 108 patients, that is 93.9 patients. Other agents that had been previously used included cabazitaxel, sipuleucel T, and radium-223. So as per the blinded independent radiological review, 53.9%, that is 62 patients, had measurable disease, with only measurable nodal disease seen in 66.1%, and the remaining had measurable visceral as well as nodal disease. 12.2% of patients had lung mets, and the same number also had hepatic mets. So more than 10 bone lesions was seen in 47% of patients. So the median treatment duration that was followed was 8.1 months. The confirmed objective response rate for the independent radiology review evaluable population was 43.5%, and for the investigator evaluable population was 50.8%. Most patients had a best response of stable disease or better. This that is 88.7% of patients in the independent radiology review population and 89.2% in the investigator evaluable population. Eight patients had a confirmed CR in soft tissue disease. Out of these, 1 had hepatic mets, 1 had a non-nodal pelvic mass, 6 patients had a node-only disease at baseline, and of these patients, 1 had a BRCA1 alteration and 7 had a BRCA2 alteration. So 70.4% of patients in the independent radiology review evaluable population demonstrated a response by the first tumor assessment that was done at week 8. The median duration of response in the independent radiology review evaluable population was not reached and was 6.4 months in the investigator evaluable population. Within the independent radiology review evaluable population, 15 of 27 patients with a confirmed objective response had a duration of response of more than 6 months. In the IRR and investigator evaluable populations, 64.5% and 63.1% respectively of patients had demonstrated at least a 30% reduction in target size lesion from baseline. 63 of 115 patients in total had a confirmed PSA response, and the median time to PSA response was 1.9 months. The median time to PSA progression was 6.5 months, with 60% patients demonstrating a single best PSA reduction of at least 50% from baseline. So we see here basically, as we saw for the investigator evaluable as well as the IRR evaluable, 43 to 50% of patients had a confirmed objective response rate, with 38.5% and 45.2% respectively having stable disease. So in this figure, basically in the above figure that was for radiographic response. So the upper dotted line that we see indicates the threshold for progressive disease, and the lower dotted line indicates the threshold for partial response. So as we see here, majority of patients had a response in the range of stable disease to partial response. In the lower image, also again, this is for PSA response. So the upper dotted line indicates a threshold for PSA progression, that is at least a 25% increase from baseline, accompanied by an absolute increase of more than 2 nanogram per milliliters above the nadir. Whereas the lower dotted line indicates a threshold for PSA response, that is defined as a 50% decrease from baseline. So again, majority of patients were in the stable disease to partial response group. So this is a forest plot. So we see. So what we see here is basically that. The data was analyzed between various subgroups. So basically, whether it was BRCA1, BRCA2, whether germline or somatic, the number of prior lines of therapy, as well as the degree of measurable disease status, the presence of hepatic mets, and age. So all these subgroups were analyzed. In general, objective response rates were similar across subgroups based on these baseline data. However, some differences were seen with PSA response rates. So among patients with BRCA1 or monoallelic alterations, PSA responses were seen, but these were at a lower rate than the overall population. However, it is important to note that both the BRCA1 and as well as the monoallelic gene subgroups, both of them were very small, so only 13 and 9 patients respectively. Similarly, a higher proportion of patients with biallelic alterations and or homozygous loss experienced a PSA response compared with the overall population. So the median radiographic progression-free survival was 9 months as per the blinded IRR assessment and 8.5 months as per the investigator assessment. So although the OS data was not mature at the time of the analysis, the Kaplan-Meier estimate of 12-month OS was 73%. So coming to the safety data, so the safety population included 115 patients who had received 1 or more dose of Rucaparib. The median treatment duration for this group was 6.5 months with a median follow-up of 13.7 months. And the mean dose intensity that we had seen previously was the actual dose received divided by the first dose received. So this was 0.88. Adverse events of any grade occurred in 114 patients, that is 99%. And grade more than 3 was observed in 70 patients, that is 60.9% of patients. So the most commonly reported adverse events were included asthenia or fatigue that was seen in 61.7% of patients, and of grade 3 or more was seen in 8.7% of patients. Anemia was seen in 43.5%, and grade of more than 3 was seen in 25.2% of patients. Thrombocytopenia seen in 25.2% of patients, and a grade of more than 3 seen in 9.6% of patients. The most frequent adverse event was thus anemia, which was seen in 25.2% of patients, and overall 32% of patients required at least 1 transfusion of packed RBCs. So coming to other toxicities, so AST, ALT elevations of any grade were observed in 33% of patients. The majority of these were grade 1 or 2 and typically occurred within the first week of Rucaparib treatment, and they normalized over time. They were not associated with any abnormal bilirubin rise or any other criteria for drug-induced hepatotoxicity. Increases in creatinine, grade 1 or 2 were also observed, and they typically stabilized by the 3rd week without a change in blood urea nitrogen. Decreased phosphate was seen in 67.6% of the patients. However, it is important to note that most patients had a low baseline phosphate, or many of them were receiving concomitant medications that were associated with decreased phosphate, such as antacids or bone-targeting agents. So treatment interruption due to an adverse event occurred in 65 patients, that is 56.5%, most commonly due to anemia, and secondarily due to thrombocytopenia and asthenia also. Dose reductions were required in 40.9% of patients, again, most commonly due to anemia, followed by asthenia and thrombocytopenia. Overall, 63.5% of patients had either a treatment interruption or a dose reduction due to a treatment emergent adverse event. 9 patients discontinued because of a treatment emergent adverse event. These included 1 patient had ARDS. This was considered not related to the drug later, but treatment was anyway discontinued. Increase in AST, ALT, and balance disorder, cardiac failure, decreased appetite, fatigue, weight loss, leukopenia, neutropenia, pneumonia, and prolonged QT. 3 deaths were seen as a result of treatment emergent adverse events. Causes were pneumonia and prolonged QT, which were both considered unrelated to Rucaparib, and 1 from ARDS. So coming to the discussion. So Rucaparib treatment demonstrated significant clinical activity in men with metastatic CRPC associated with a BRCA alteration. Meaningful radiographic and PSA responses, including complete responses in soft tissue disease, have been observed with a manageable safety and tolerability profile. Although more than 60% of patients had grade 3 adverse events, this was limited to anemia, thrombocytopenia, and ischemia, and all of them were easily managed. Based on this, Rucaparib was granted accelerated approval by the US FDA for the treatment of men with the deleterious BRCA mutation, germline or somatic, associated metastatic CRPC who have been treated previously with the AR-directed therapy and the taxane-based chemotherapy previously. So baseline characteristics in the efficacy population were as expected for a population of patients with metastatic CRPC receiving third-line or later treatment. More than 1/3 of patients had been treated with at least 2 next-generation androgen receptor-directed therapies. Also, so for men with metastatic CRPC who have progressed after next-generation AR-directed therapy and taxane-based chemotherapy, response to previously approved therapies has been historically poor, with confirmed objective response rates ranging from only 8 to 15% and a PSA response rate ranging from only 8 to 39%. Thus, this data from Triton-2 illustrates the importance of genomic screening to identify men who may benefit from treatment with a PARP inhibitor. So these patients with metastatic CRPC who had a BRCA alteration who received Rucaparib had substantially higher resistant PSA response rates than those that were typically observed with other treatments in an unselected population. Also, responses in clinically relevant subgroups were studied as well, and these were significant. So confirmed objective response rate of 46.2% of patients was seen, that is 6 of 13, among patients with hepatic mets. And this is known to be an indicator of poor prognosis in metastatic CRPC. So responses were observed in patients with both BRCA1 and BRCA2 alterations, germline as well as somatic alterations, and all categories of alteration in zygosity. Rates of confirmed PSA responses were higher in BRCA2 versus BRCA1 and biallelic versus monoallelic subgroups. However, as we mentioned earlier, it is important to note that the number of patients in the BRCA1 and monoallelic subgroups was small. Also, due to the limited number of tissue samples received, alteration zygosity could only be determined in 39% of patients based on the availability of sufficiently high quality NGS data. Despite relatively small numbers, confirmed PSA responses were observed in all molecular and clinical subgroups that were examined. So all these results that we have seen are consistent with those from other studies that have demonstrating the clinical activity of PARP inhibitors, including olaparib, niraparib, and talazoparib in patients with metastatic CRPC and a BRCA alteration who have received prior androgen receptor-directed therapy. So coming to a few of the studies that have evaluated PARP inhibitors in metastatic CRPC previously. So this was one of the earlier studies, a phase 2 trial on olaparib in NEGM 2015, which enrolled 50 patients, all of whom had received prior treatment with docetaxel. Additionally, 98% of patients had received abiraterone or enzalutamide, and 58% had also received cabazitaxel. 53% had a response. 3% of these were found to have homozygous deletions, mutations, or both in DNA repair genes, including BRCA1, BRCA2, ATM, Fanconi's anemia genes, and CHEK2 and NGS. 88% of patients had a response to olaparib. including all 7 patients with BRCA2 loss and 4 or 5 patients with ATM aberrations. Again, anemia and fatigue were the most common adverse events. The other study includes Rucaparib, which studied Olaparib, again a phase 2 trial. So here, both 400 milligram and 300 milligram doses were studied, and a confirmed composite response was achieved in 54.3% for the 400 milligram cohort and 39% for the 300 milligram cohort. A radiological response was achieved in 24.2% of patients in the 400 milligram cohort and 16.2% of patients in the 300 milligram cohort. Again, most common grade 3 to 4 adverse event in both cohorts was anemia. So there was the Galahad study was on Niraparib. This was a phase 2 study which assessed Niraparib in patients with metastatic CRPC and DNA repair gene defects who had previously progressed again on taxane and androgen receptor directed therapy. So among patients with BRCA mutations, objective response rate was 41%, and the median duration of the objective response was 5.5 months, and the median PFS and OS among BRCA patients were 8.2 and 12.6 months, respectively. The PROFOUND study was another study. This was a phase 3 study in patients with BRCA alteration and prior androgen receptor-directed therapy, which showed improved PFS with Olaparib versus abiraterone acetate or enzalutamide, with a median of 9.8 versus 3 months. So coming to a discussion in the safety data, so consistent with that observed in, so the safety profile that was seen in this study was consistent with that seen in prior studies in other solid tumors such as ovarian cancers, and also in metastatic CRPC who have received other PARP inhibitors. So most commonly asthenia, fatigue, GI adverse events, and myelosuppression. Elevations in ALT, AST, and creatinine were common, however they were not associated with liver or kidney toxicity per se. The creatinine rise has been observed in multiple PARP inhibitors and is thought to be due to an inhibition of renal transporters such as MATE1, MATE2K, and OCT2 rather than a direct impact on renal function. ILD has not been identified as a potential risk for Rucaparib treatment when evaluated across studies in multiple tumor types. So coming to the strengths of the study. So the study included both independent radiologic review and the investigator-assessed endpoints. A substantial proportion of patients achieved a confirmed radiographic response with Rucaparib via both assessment methods. There was a discordance in assessment by independent reviewers and investigators, which may be influenced by variations in lesion selection or by historic clinical information available to the investigators, but not the blinded independent radiologic review. So coming to the limitations of the study, the duration of response and PFS results for the independent radiology review evaluable population were more heavily impacted by censoring. So radiographic assessments were to be continued until disease progression was observed by the investigator. So if the investigator reported disease progression on a scan, but the blinded IRR did not, the patient became censored in the IRR analysis. Additional limitations that were noted by the study authors included the lack of a control arm. So coming to a critical appraisal, so this was a phase 2 trial, which is useful in terms of safety and efficacy data, but of course, further data would be required to confirm its efficacy. The subgroup populations that were studied, including BRCA1 and the monoallelic mutations, were too small for a meaningful comparison. Also, the OS data at the time of analysis was immature. So coming to the SWOT analysis, so this was the first study reporting on the efficacy and safety of Rucaparib in metastatic CRPC patients with BRCA gene alterations. It was a phase 2 study with immature OS data. So these were the weaknesses. Future opportunities included a phase 3 study, which would evaluate the PFS and OS, and also to study the role of Rucaparib in an earlier disease setting. No threats were observed. So the future directions include the phase 3 Triton 3 study that is ongoing to define the clinical benefit, that is radiographic progression-free and overall survival of Rucaparib in an earlier disease setting among patients with metastatic CRPC associated with a BRCA or ATM alteration who have progressed after one next-generation ER-directed therapy and who have not received taxane-based chemotherapy in the metastatic CRPC setting. Rucaparib in this study would be compared with the physician's choice of next-generation androgen receptor-directed therapy or docetaxel, and will provide additional evidence of the effects of Rucaparib treatment in men with metastatic CRPC. So finally, results from this study, the Tritons 2 study, demonstrate that Rucaparib has meaningful anti-tumor activity and a manageable safety profile in patients with metastatic CRPC, as well as a deleterious germinal and somatic alteration, and support the use of Rucaparib in this patient population. Thank you.
Super, very nicely done, Laboni. Really nice. Akhil, you want to start?
Yes, ma'am. So Laboni has definitely summarized all the data which is available. Also, she has touched upon beautifully the all trials, including the SWOT analysis. So this is the way a journal club should be presented. This should be an example, and all residents should make a note. This is the format which they can adopt for presenting a journal club. So beautifully done, Lavani. So Lavani, can you start with telling us the definition of PSAWG3 criteria?
So, sorry, sir?
PSAWG3 criteria, which was used in this trial, which is the standard definition to notice PSA progression.
Yes, sir. So PSA progression that was seen of more than 25% or an increase of more than 2 nanograms per milliliter from Nadir.
Okay. And there should be a single value or two separate values?
Two separate values, at least 3 weeks apart.
Great. So this is another important point. A single PSA value should not change the treatment unless otherwise you see that the patient has definite clinical progression. Just some increase in PSA should not change the treatment. That is important. So most of the studies actually warrant to use a combination of clinical plus radiological progression. So here also in this study, radiographic progression-free survival was the primary endpoint. This is the same with the profound trial as well. Let me ask Dr. Kunal, are you there?
Yes, sir.
Kunal, can you tell something about profound trial? What was the design and something in detail about the profound, because that was covered in very brief. So can you highlight about the same? Because that is another important trial which needs to be discussed along with this trial.
Yes, sir. Sir, it was a randomized phase 3 trial in patients of metastatic CRPC and who had progressed with prior hormonal therapy, abiraterone and enzalutamide, and around there were 2 cohorts were used which had BRCA mutation, and other cohort had genes of the hormone HRR pathway genes. And the thing was that patients only around 20% patients had received prior taxanes, and around 20-30% patients had already received enzalutamide and abiraterone previously, and then they were subsequently randomized to the olaparib arm versus the hormonal therapy, that is abiraterone or enzalutamide arm, and it showed a PFS advantage of around addition of around 3 to 3.5 months, and OS advantage of around 4-5 months. But it had several caveats because of the prior therapy. The taxanes was received only in 20%, and patient already received abiraterone and enzalutamide in another quarter of patients.
Okay, so what I wanted to get the information which you have already given is there were 2 cohorts in that study, which include cohort 1 included BRCA1, BRCA2, and ATMG. This is based on the previous trials, which Lavani has shown, the phase 2 trials of olaparib, where it has clearly shown that these 3 genes are getting the maximum benefit. That is why they included these 3 genes in cohort A, where they were sure that they will get response. In the cohort B, they included 12 other genes, which are the part of the HRR panel. So in HRR panel, which was used in this olaparib study, that is profound trial, there are 15 genes. However, later during a protocol amendment, they removed 1 gene, which was triple PAR gamma 2. So that was removed. So our total 14 genes were included in HRR pathway mutation testing, and the 3 genes, BRCA1, 2, and ATM, this was kept in cohort A. Rest genes, 11 genes were kept in cohort B. So finally, the radiographic progression-free survival, which was the primary endpoint of this study, was found to be statistically significant in cohort A. In cohort B, the numbers were also smaller, so we are not sure. But though FDA label is to offer olaparib in both in all HRR mutant, it is a category 1 recommendation, as Lavani has shown in the NCCN recommendation. But we know that this is the BRCA1, 2, and ATM which will get the maximum benefit. And also, Lavani has shown that out of the 7 patients who had ATM mutation, there were 5 patients who had responses. So it seems that ATM is also nearly similar efficacious with the PARP inhibitors. The Triton 3 study, which Lavani has shown that is accruing now, this is a somewhat similar study design which was done for profound study. So these are the important things which needs to be highlighted. Again, one point. Lavani, do you know Rucaparib is available in house or not? Lavani?
Yes, sir. Rucaparib.
Is it available in TMS pharmacy or not?
I think it's not available, sir.
It's available. It's available from last 3 months. So, the benefit of Rucaparib is that it is there are 2 generic molecules which are available with us. That is the main benefit, because we know that olaparib has some exorbitant cost, though it has some support programs as well, but still olaparib cost close to 1.2 to 1.5 lakh per month with support program. But Rucaparib generics are available with us, which cost close to 50,000 per month. So this should also be noted, because when you are counseling a patient, we need to be aware of the cost of the treatment so that we can counsel in a proper way. Vanita, comments from your side?
Yeah, I think a few questions. Laboni, can you go back to the definition of radiographic progression-free survival that was used? What was the scan that was used for radiographic PFS? Was it PSMA or was it regular CT scan?
Actually, they've just mentioned radiographic progression. They've.
Okay, maybe we can go back and look at the protocol. And this is a genuine question that I actually don't know the answer to. So when you talk about time to PSA progression, or you talk about PSA progression and you have to confirm it 3 weeks later, so that's almost a month. What date do you use as as your event date? Did they specify that?
So actually, they did not specify. I think it. What I felt would the date of the first PSA that was documented to the first PSA value, and then the 3 weeks after that. So I'm not sure.
Okay, because you would, if you have to confirm it, you would continue your therapy. So actually, the patient is continuing the therapy until the second date that you have confirmed.
Yes.
So because we are facing this issue in our trial, and I don't know how to answer these questions that are raised by DSMB. So I wanted to know what everybody else's opinion is. And when we are doing the PSMA PET as well, we see a lot of lesions, especially the bony lesions, and you see some new lesions. And so is there a specific definition about what would constitute progression, radiographic progression? I think the PSWG does not define at least the scan, because I think PSMA PET is relatively newer in our armamentarium. Akhil, what are your thoughts?
All these studies are used as CT scan plus bone scan as the that is the main problem. So even with the trial, trial which we are doing, there is sometimes confusion. But I agree, ma'am. When we get, if there is only if there is PSA progression, we will take the second date on which we have shown that it is progression. Because if the patient has gross clinical progression, we usually don't wait for 3 weeks, because if the patient has documented skeletal related event or anything, then the one rise in PSA, or even if PSA is not rising, but there is skeletal related event, it becomes an event for us and move to the next. But
is this defined somewhere, or this is what you feel?
No,
You
ma'am.
take the second or the first?
This is even in the ICMR guidelines as well, ma'am.
For PSA progression. So
Yes.
second, they specify that the second PSA has to be taken.
ICMR guidelines, which we are sharing. This is under publication. ICMR guidelines. I am one of the writers for that ICMR guideline paper. So we have specifically included these points as well.
Okay, good. Thanks. So that's good to know. My second question or comment, I guess, to Laboni is what is the recommendation for testing? So should you be testing HRR, BRCA1, 2? How do you test? What and at what stage and what exact test should you do? Laboni, are you there?
Yes, ma'am. So recommendations currently for, I mean, it's BRCA1 or BRCA2 testing would be recommended in patients who have progressed on the initial line of therapy. I'm not actually sure, ma'am.
Not ATM and not at baseline. Anybody else? Any third year?
Rahul, would you like to comment?
Sir, I think the whole HRR panel, which 52 genes, it would be better to assess because, like in OVD, BRCA NES can be seen with.
So it seems the recommendation is when you are starting a treatment with olaparib, the recommendation is to test for HRR. But even if you do BRCA1 and 2 testing, that covers maximum of the patients so even when we use AstraZeneca coupons for testing, they for prostate cancer they have included only HRR. They don't include BRCA1 or 2 testing as a part of the coupon at all, because this is the FDA label that HRR mutants will be given olaparib. So this is, if you are testing for olaparib, do complete HRR testing if feasible, by cost, by everything. But if you want to use Rucaparib, presently it is approved only for BRCA1 and 2, and we are till the results of Triton 3 are out, we can offer Rucaparib to BRCA1 and 2 only. And also, based on the profound data, we know that it is only the 3 genes which are getting the benefit: BRCA1, 2, and 18. Other cohort, though it is approved for all the 14 genes, but we know that the main benefit is in 1, 2, and 18. So these things will drive the decision.
Yeah, agree. I think then only the other question I had is what. So now we have multiple options, right, Laboni? What is your recommended sequence of events? So I think in the last few, like maybe a year or so, we have got PARP inhibitors, we have got lutetium, PSMA, chemotherapy. So what would you recommend? Yeah, and anyway, Pele we have the newer androgen receptor blockers as well as taxanes. So what is optimal, perhaps, sequencing of therapy in a patient with CRPC? So maybe first you can talk about non-BRCA mutated and then BRCA mutated.
Yes, ma'am. So actually, so if a patient has previously received a taxane and a prior androgen receptor targeted therapy, the category 1 recommendation is still cabazitaxel, and the other recommendations are mostly for patients of with certain other characteristics. Like for example, if HRR a mutant, then olaparib. Then if MSI high, then pembrolizumab is an option. And for BRCA1 or 2, then Rucaparib can be used. So
you are saying that if your patient has BRCA2 mutation, you would treat the patient with an androgen receptor blocker, say abiraterone, then you would use, say, docetaxel, then you would use cabazitaxel, and only then you would introduce a PARP inhibitor. So is that did I understand you correctly?
No, ma'am. So currently, as per this study, this study was done in patients who had previously received a taxane and either 1 or 2 prior androgen receptor therapies. So here I would, after the patient has, initially if the patient has received a docetaxel or an androgen receptor therapy, then next I would consider a Rucaparib after that, because I mean, because there is evidence of efficacy in this study. So.
Yeah, I agree with you. I don't think we have data to move it up earlier than that, but I mean, the feeling is perhaps that it may be better earlier, but yeah, I agree that the data says this. Okay. I don't have any other additional questions or comments. Anybody else?
One more comment from my side. PSMA therapy, we are, though it is not in this NCCN recommendation, we are using in a significant number of patients already, even at Mumbai and also at Varanasi. So patients who are candidates for the same, that means they have intense PSMA expression. They are candidates for PSMA therapy, lutetium PSMA therapy. So when you want to use lutetium PSMA therapy, this should be kept in mind. The PSMA therapy leads to some amount of myelosuppression. So it is somewhat like chemotherapy itself. So if you want to PSMA therapy, reserve it for at least the patients who have received prior docetaxel, cabazitaxel. At least these two drugs should have been used. Because what happens if you have not used cabazitaxel in patient and you start PSMA treatment, later on it is difficult to give drugs like cabazitaxel because there will be more than expected myelosuppression. So this should be kept in mind while deciding the treatment sequence. Also, olaparib or rucaparib, these also cause some significant amount of neutropenia along with anemia and thrombocytopenia. So again, so if patient is BRCA mutant, we try to use olaparib or rucaparib before PSMA therapy. So these are some of the practical and important points. Regarding cabazitaxel, we had the data of CARD trial which showed that it should be preferred treatment over the next abiraterone or enzalutamide. For example, I will explain it with an example. Patient received abiraterone, docetaxel in the first line, abiraterone in the second line. Now the third, what it should be the next line of the treatment. There's clear data to show that if you use cabazitaxel versus enzalutamide in this setting, the patient will get a significant PFS benefit by using cabazitaxel based on the CARD trial. So these things should be kept in mind while deciding the sequence. However, I completely agree. The sequence is needs to be tailored as per the individual patients. Any other comment? Amit Joshi, sir?
Actually, I think in this ASCO there was a very recent data about the abiraterone plus olaparib irrespective of the HRR, and I think the result of that trial was positive, and RFS was the endpoint, and it was around 24 versus I think 12 or 30 months, and both the HRR mutated versus non-mutated both benefited. Definitely the hazard ratio was better for the mutated. So I think in the full paper is awaited. So I think in next 6-8 months the paper will be there. Then whether to do HRR in patients who are affording for that, or even not, you can use. So I think it was a proper trial. It was a phase 3 randomized trial. So I think things become further complicated when the data of that proper trial will full paper will come. But definitely there is enough evidence so that the combination of abiraterone with olaparib has some additive effect, so which even the patient without HRR mutation may get benefit, and that the trial results showed that. So I think, and it was in CRPC post progression over the so if the docetaxel was allowed. If I'm not very sure about the docetaxel, but I think it was allowed. So it was the post one line of chemotherapy progression. So I think in the HRR mutation. So now the currently prostate cancer management is very rapidly evolving, I think. Yes. So we have to modify as per our need, our requirement, our own patient need. We have a lutetium PSMA. So as you rightly said that we keep the lutetium PSMA when at least the patient is not able to take chemotherapy. If the patient is able to tolerate the chemotherapy or in a general condition, we keep that in reserve because we don't know how the bone marrow will do. So I think it's a rapidly evolving concept of a CRPC or overall metastatic prostate.